So today I'm going to talk about our research on developing some statistical methods and within, you know, the causal inference framework together with machine learning and on how to evaluate the personalized dynamic treatment decision rules. To start with, I will go through some introduction of the background of this topic. And we all know the precision medicine and personalized healthcare is an emerging field that can tailor the treatment, try to customize the healthcare to each individual. And in this field, instead of one size fit all type of treatment, we want to use the treatment and to use everybody's their own information to tailor the treatment and strategize that to account for patient heterogeneity. And we all know patients are different, and this kind of a heterogeneity potentially will be there in their response to your treatment assignment. And this kind of heterogeneity may happen because patients are different from one to another, and what treatment works for one person might not work for the other person. That kind of, going across different patients, you have different heterogeneity. In the meanwhile, this heterogeneity also happened within the patient itself. So for example, sometimes what works now for me, maybe after 2 months, it no longer worked. Or maybe you develop some side effects or you recovered. So we want to think about how to switch you to another treatment alternatively. So to personalize the healthcare strategy, we want to account the following two layers of different things. One is treatment individualization. And that means at any given disease stage, we want the optimal treatment is assigned to the patient based on the patient's specific characteristics and their medical history. So that means we will tailor the treatment to the heterogeneous patient characteristics. And in the meanwhile, we also want to account for the time varying things. And therefore, we will have the treatment adaptation. We want to adapt the treatment over time due to the time varying disease status, and also want to balance the treatment effectiveness, maybe side effects, cost, and everything together. So that means over time, we want to select the optimal treatment strategy dynamically. And here's an example to illustrate what kind of this dynamic treatment procedure is. And this is an example from MD Anderson Cancer Center, how they take care of their patients. These are their esophageal cancer patients collected, the information are collected a long time back from 1998 to 2012. So they have over 1,000 patients, which is very nice for us to study. And then, what is happening is that they have a patient diagnosed with the disease, so the patient comes to the clinic, and then you start to evaluate the patient. And besides, collecting their demographics like age, gender, BMI, race, you also will do a bunch of, lab tests and evaluation. For example, here we got their ECOG oncology kind of like a performance status. Also their PET SUV value and whether the patient has hypertension or the lesion location, histology, tumor differentiation, tumor size, tumor length, and overall cancer stage. You can have potentially a bunch of those. Besides those, you may have biomarkers as well. So we put everything, like baseline variables. And what do we use those, variables for? For the physicians, very obvious they will use this information to decide what kind of treatment they will offer, right? So in this case, their first stage treatment will be induction chemotherapy, yes or no. And after the patient is offered the treatment, you don't stop there, right? So you will ask the patient to come back, you will keep observing the patient. And for example, in this case, they will see whether the tumor responds to the treatment, which we call the intermediate measure or intermediate response variables. After you observe those, you can decide the next step, what treatment to offer as an alternate or salvage treatment. So in this example, their salvage treatment will be including the radiation modalities, include 3D CRT, IMRT, or proton. Okay, and then you can continue doing this, follow up the patients, and then changing the treatment, adjust the dosage, and then until the end, you probably want the long-term goal is to have the disease to be well controlled, and to have the tumor respond very nicely, or no new lesion happening anymore, and also you want to manage the side effects, for example. So there are a lot of long-term goals are together with some intermediate goals. So how to combine them together to make a judgment on the treatment decisions. So this is really what is happening in the clinic, in the practice. And what we want to try to do is get the quantitatively measured evidence and use the data to drive our informed decision making. And that is what we want to address today. So then obviously the question is how to quantify the patient differences. Maybe this kind of eyeball, if I give you these two gentlemen, and then do you think like which one will respond better to their treatment? Who is healthier, right? So obviously we don't want this eyeball test to say, oh, you will respond better, the muscle man may be stronger, right? So we want to leverage all the data. And luckily, nowadays, with the advance of technology, you got to be able to have all different kinds of data. Maybe it's too much data for us, but it's good that we can quantify a lot of things. And for a disease to happen, there are many things happening around you, many things happen inside you. And this figure was created by one of my collaborators, Professor Wang. And Stu mentioned that for a disease to happen, you may have internally from the genes to proteomics and maybe some cells, tissue, organs that can be viewed or visualized from the CT image, from MRI, and you can see some change internally, internal risk factors. But outside your body, you may have nutrition risk factors, environmental risk factors, your exposure to the disease or to the microbiome. So all of these things, you want to see, maybe what risk factors is useful for you, for disease diagnostics, and for you to assign treatment, okay? Which variables could potentially be used as a tailoring variable, those variables that help you to tailor the treatment assignment to achieve better health outcomes. So you may also have some interactions between these internal risk factors and external risk factors. So for example, the gene environmental interactions, right? So our job is to provide a machine which is like this engine. That is our statistical tools or your method, your algorithm. And our goal is to leverage all the data we collected from the family history, from your medical history, genetics, or your lifestyle, environmental risk factors, and we put everything into our machine. And instead of to have one size fits all type of treatment, we kind of integrate some degree of tailoring and to realize or make it to be possible to achieve individualized therapy. And that means we want to find the right drug with the right dose at the right time, which is pretty much individualized to each person to provide meaningful, improved health outcomes for your patients. And that is what we call dynamic treatment regime. So this regime is a mechanism. This actually is a sequence of decision rules. It's not like regimen themselves. It's actually how to use variables mapping to the decisions. So it's a sequence of decision rules, one decision rule per stage of the disease progression that can map patient-specific features to a recommended treatment. And of course, I do not want my machine to be a black box. And I want black box type of dynamic treatment regimes are unlikely to be practiced. So I don't want something happen like, oh, you ask the machine to say, oh, this works for the patient, but how, why? So it's more critical to communicate with your physicians, with your patients, how this data-driven dynamic treatment regime help. We want that to be more transparent and so that they can trust our decision rules. And in the meanwhile, if you have a clear form to tell them, oh, these are the most important tailoring variables, and according to this variable, if that biomarker, the value is over some value, you need to be careful. You need to treat certain way. For the other group, you need to treat another way. We want this kind of thing to be more practical, and then the physician and patients can use them to guide their own treatment decision. So that will be more impactful. So these things, we call that as interpretable dynamic treatment regimes or viewable dynamic treatment regimes. And I list a bunch of literatures here. Of course, nowadays they have more and more related very excellent papers. So please feel free to go through the literature and search on that. So viewable dynamic treatment regimes, backward outcome weighted learning, adaptive contrast weighted learning, tree-based reinforcement learning, and list-based dynamic treatment regime, and stochastic tree search. And this list goes on and on. So now let's frame everything in our mathematical models and to mimic what is happening in the real practice. And we are going to use X1 to denote the baseline information. And based on the baseline information, you will be able to decide what is my initial treatment. So the random variable here, treatment at time 1 is A1. And following that, you continue to update the information either medically or for their other demographics or social economics, those kind of status, you may update those information as well. So you have longitudinal measurements along this way. And then based on this updated information, maybe more lab tests, more results and biomarker changes, you want to say, oh, what is my next treatment I can offer? So this A2 is the treatment at stage 2. You can continue doing this until the last stage, and we will use big T to denote the last stage, and we'll have updated information at last stage and offer the last treatment AT, and then get to the long-term reward function you want to achieve. That is our desirable health outcome. And this this Y could be a function of all the past responses. It could be by itself to be long-term survival itself. So it's very flexible, the whole framework to capture different kind of rewards you want to have, okay? So now, at any, we use the little t to be the decision point. So that goes from 1, 2, 3 until big T. So then you have decision stage fixed at 1, 2 until big T. So at each stage, each decision point, what you get up to date. So up to the time T, what you observe, let's say something in the middle, what you observe will be this bunch of covariates happening in the past, including baseline and updated information. You also get the treatment history, right? So putting them together is our up-to-date patient information, okay? And the other thing I want to mention is here, the treatment is not only yes or no or binary treatment. We actually allow that to be this arrow is a little bit tricky. Okay, there we go. Right. So this treatment could be multi-categorical as well. So you could offer them A, B, C, D, 4 different kind of treatment, and then they're going to decide. And that number of treatment options at different time could vary as well. So we use KT to denote that. Okay. So where is our rule? Okay, that's a key point. So now we want this function G, and G, the whole bolded G is a vector, which is a sequence of decision rules. So we have a G function at each time point. The G of T at time little t is a mapping from your current history mapped to the treatment options. So our goal actually is to find which G is optimal. Okay? Yes?
So you typically use the entire history here and not like in a Markovian way?
Yes, that's a very good question. So the whole framework does not necessarily need to have, Markov assumption. We don't need that. But in some situation when you have tons of data, you probably want to assume Markov assumption so that it can simplify your models. Yeah, good question. Other questions? All right, so now what we want to do is, in this counterfactual world, we use Y star to denote the counterfactual outcome. So this is different compared to Y. Y is your observed outcome, but Y star is if everybody is following this G decision rule. Even though everybody is following decision rule G, but I have my own history, so I get a different treatment individually. But my Y star is called a counterfactual outcome under the decision rule G, okay? And my job is to argue max, so try to find the decision rule that will maximize this expected counterfactual outcome mean. Okay, so you may notice that I have two jobs because I want to have a good estimate of this expectation, and secondly, I want to search going across a class of decision rule of interest to see which one is optimal. Okay, and maybe some of those who are familiar with the causal inference also notice that Y star in this case actually cannot be observed for everybody. Because in reality, if I follow this treatment path, I cannot have my outcome to be observed for another path. So along all of these counterfactual outcomes, you can potentially have a lot of missing data. So that is why this whole framework is within the causal inference, and all the technical part or skills you develop the method is related to missing data analysis as well. So maybe many of you are familiar with. Okay, so my goal is to find this regime, the decision rule that will yield the maximum average outcome if everybody is followed the decision rule G by the whole population. And in order to have this identifiability, then I need to have the following causal assumptions. The first one is no unmarried confounders. That means given the existing data, there is no other variables who are confounding the treatment with the outcome. And then the other assumption I need is called consistency. That means, if everybody is following the same treatment, their outcome is unique. They cannot have, if I take aspirin from using water versus next day, I take that with milk, I have different outcome. So we don't allow that. So we say, with consistency assumption, that is ruled out. And the last assumption for the causal inference is positivity. That means for every treatment options, you do have data in your existing data sets that somebody is following that. If nobody is following that treatment, of course, I cannot make any causal inference. Okay, so with all of these causal assumptions, we will be able to have a good estimate of this expectation and have a certain algorithm. So that is actually for where every stage or stage specific algorithm, you have a basic idea. Hopefully you have a basic idea now. So one more complication in this whole thing is actually comes to this is dynamically over time. So what is happening is from the baseline measurements, you have your stage 1 treatment. After your stage 1 treatment, you have your intermediate outcomes. And these intermediate measures will have an impact on what treatment you are going to choose next time. And this treatment will have an impact on your outcome as reward function as well. So you do have something happen after some treatment that is not the last stage, which have the treatment indication happen afterwards. In the meanwhile, you have time varying confounders. So in that situation, let's say, if this treatment is happening at the end, everything happened before, all the confounders, all the treatment previously, you can control for them. And then your results from the whatever model you fit, it has a causal interpretation. But if that happens before, and then some confounding happened after your treatment assignment, you cannot control them in the model. And of course, you cannot like no control, because either way, it will cause a bias, right? So what we will do is call this backward induction for the dynamic treatment regimes. And what you will create is something we call pseudo outcomes. So at any intermediate stage T, we will consider a counterfactual outcomes, and this outcome will assume at current time T, all the future are already optimized. All the past are given, you can conditional on. So then you can make a causal inference. So then what will happen is, how do I know like this is the future one to optimize? So that means in the future steps, I already know which one works the best. So what you will do is you create a pseudo outcomes and adding back in the future steps whatever loss comparing the optimal, your estimated optimal versus your observed. So adding back the suboptimal loss to. Okay, so then that is a backward induction. You run the algorithm from the last stage and go backward. All right, so one approach, a whole school of literature, actually solved the problem using classification. So if you imagine that, basically, if you only have binary treatment, what you will do is you want to see whether my decision rule can offer the best, the treatment option that I want. So it's just binary, yes or no. That is actually a classification problem. The complication actually comes to the case when you have multiple treatment options. You cannot say, oh, I have an indication this is comparing to A to B to C to D. You have a multiple comparison there, right? So what we did is we incorporate the other statistic. For mu of age, conditional on your past history, we have a augmented AIPW is augmented inverse probability weighted estimator for your conditional expectation of your counterfactual mean. And that is actually individualized order, okay? And we use that, the maximum, the optimal one, to to create a contrast. And this adaptive contrast first of all, is adapt to each patient because everything is based on the age, is conditional on age, their own history. And secondly, then these create a weighted version of the classification. And those of you may notice that, this is not a classification as yet because these are not common, so cannot take it out. But we found this, actually, there is a summation, but each one of them is bounded between the maximum loss versus the minimum loss. The maximum loss will be using the other statistic of your conditional mean is the best one, the optimal option versus the worst. And then the optimal one versus the next to the optimal one is the minimum loss. So actually, if you use that bounded between those two, you can take this weight outside of the summation, and that becomes a weighted version of classification. Okay, so the bottom idea, is you want to minimize this expected loss in your outcome due to the suboptimal treatment. In the meanwhile, this adaptive contrast will classify as many patients as possible to their optimal treatment. Okay, in the meanwhile, they put the more emphasis to the patients with larger contrast, and therefore this whole algorithm will minimize the expected loss among the entire population of interest. Okay, so this is have several advantages. First of all, is weighted classification, we all know how to implement it, right? And then the results are also very easy to interpret. Okay, there's one drawback is you can see my original goal is to maximize the potential outcome, but now I kind of like go back to the population in the data set to minimize the loss. So it's kind of a transition from there to minimize the loss as a purity, right? So the other approach So here, this is a tree-based reinforcement learning approach. This approach will combine the double robust AIB double estimators with non-parametric machine learning methods, and they actually will create a purity measure, not the classification purity type of error thing. And I'm going to create a purity measure to improve the expected counterfactual outcome at each stage J. So what they will do is, for a given partition omega complement of any node, and if I denote the G, J omega A1, A2 to be the decision rule that will assign treatment A1 to omega 1 partition, treatment A2 to the complement part omega C, okay? Then I can define the purity measure as a summation, empirical summation of all the possibilities of these partitions to see whether this purity measure is improved if I go with a partition, or should I stop there, right? So that this purity measure, the P, actually evaluate the performance of the best decision rule that assigns a single treatment for each of the two arms under the partition. Okay, and it's also more directly connected to our original goal to maximize the counterfactual outcomes, right? So to illustrate how this works, so in this figure, we have a tree type of decision rules, and we have several covariates, x1, x2, okay? And they have a bunch of other variables. And in this case, only two important variables are useful for your treatment assignment. One is x1. So if I do not consider these covariates, I basically have the option of treatment 1, 2, and 0. Okay, so what I'm doing, what the typical causal inference will compare treatment 0, treatment 1, treatment 2 to see which treatment is the best, the average causal effect, right? So then we notice, oh, for treatment 1, that is the best, and the expected value will be 0.7. But now if I integrate the tailoring variables, and I notice that if I split my population by their biomarker x1 value, if that is negative, I go to here and to assign the treatment 1 to this group. If not, I assign them to be treatment 2. And then in each subgroup, you may notice that their expected counterfactual mean actually got improved, right? So this is 1.5, this is 1.7. And each of them is higher than over one size fits all type of treatment. Okay, you can continue to think about the next covariate, whether it's useful or not, according to our splitting rules. And then we notice that, oh, x2 actually is another important tailoring variable. And this biomarker has a cutoff value as 0.5. If that is less than 0.5, you should assign treatment 0. Otherwise, you should assign treatment 1. So now using x1, x2 to individualize your treatment, you might notice that at your end node, okay, your leaves of your tree, each group has their outcomes, potential outcome, greatly improved. So this is 2, 2.2, greatly improved compared to here, compared to here. Okay, so that's how this works. And then through this whole process, you can have the individualized treatment. Okay, so here are some simulations, and then the first simulation setup is the underlying decision rule is a tree type. Okay, and then we actually found that for the tree-based reinforcement learning performed really well. So here we have two sample size, 500, 1,000. And then this column is optimal percentage is among the data, how many patients are assigned to their optimal treatment. So you want this percentage as high as possible. The second one is expected value of the counterfactual means if everybody is following your estimated decision rules. Okay, so you can see that for your results in this red box, this is pretty decent, and will increase sample size that can go to 95.7%. And then their expected value is also higher than the other approach. So this first one is Q-learning, that is backward outcome weighted learning. And then the part that is in this blue box are adaptive contrast weighted learning. And then that one actually works okay, but not as good as tree-based reinforcement learning because when you simulate the data, the underlying truth, it is a tree type, right? So that's reasonable. And these results also demonstrated the double robustness because you use AIPW estimator. Okay, if the Pi model is correctly specified, the results all good. And if that is not correctly specified, you still have double robustness. The results are decent as well. Okay. So we also create a simulation setup where the underlying truth is not tree type. And then in that situation, of course, this tree-based reinforcement learning doesn't work as well as before. But the adaptive contrast with weighted learning actually are pretty robust because they don't depend on tree type in their process, right? And in the whole like tree growing process, you may have potentially a big problem. You could potentially overfit the data. So that motivated our research in 2021. This was published in JASA, and we call that as stochastic tree-based reinforcement learning. So again, you have two jobs. One is to estimate this counterfactual expectation. One is to do the search. So this method actually use the Bayesian tree in the ensembles to estimate this counterfactual mean. And for the searching job, that part of the algorithm, we use Bayesian cart to do the stochastic tree search. So first of all, this has a very good advantage. It's non-greedy. So that allows mistakes to happen in splitting. And then it uses MCMC algorithms to stochastically search with 4 proposal choices. So the first two, tree grow, tree prone, and tree change, that is a typical tree grow, even in the tree-based reinforcement learning, they have those two proposals. But in this new algorithm, they allow 2 new ones. One is called swap, one is called restructure. So what that means is if you look at this figure, so this has x variable, x2 variables. So x1, x2 are 2 important tailoring variables. And according to that value, you can see you should be assigned to different treatment. A, B, C, D are with a different color, meaning that they should be assigned to 4 different treatments. Okay, and then if I go with enter x2 first, and I use x2 value to be cut off first, and I could go with these 2 branch down there. But actually, after I got to this tree, I allow these 2 children node to swap, so they could change. And I also allow that to be restructured, meaning that I will, instead of to go with x2 first, I can go with x1 first to restructure my tree. Okay, so this kind of thing actually can help the algorithms to be more robust against overfitting, and computationally it's also manageable. And we also evaluated their theoretical properties, and we found that for the tree complexity, if we use the little st to denote the number of leaf nodes, and then this sample tree size actually have this quantity, the probability this the number of leaf nodes go beyond certain order of n actually goes to 0. So that means the tree size can grow sublinearly, and this can greatly help us to prevent from overfitting. And in the meanwhile, this actually suggests us that this searching process will concentrate on smaller trees, and that can greatly reduce the searching space, which is also very helpful. And in terms of, for the real practice, the physicians also prefer to have smaller trees instead of too many dimensions of data to make a decision. They want to catch the major signals. And we also try to evaluate how close your estimated decision rules compare to the optimal decision rules, or in terms of your reward function. This V stands for value function, the same as reward function, different terminologies. So how these value functions for your optimal decision rules versus your estimate decision rules, how far they are from each other. And then these results actually show that your proposed estimator is pretty consistent. However, the rate of convergence is determined by the convergence rate of the conditional mean. And also, when you have a multiple treatment stage, there is a potential issue of non-regularity. So this also depends on non-regularity degree in the estimating procedure. So we also performed some, conducted some simulation, and it shows that the performance of the stochastic tree search is pretty decent across various scenarios. So here I only borrowed one figure. So if you want to have more information, you can read all the papers. So I will leave my slides to Dr. Lahar, and she can share with you. And I list, for each slides, I have the paper listed there. So if you want more details, you can read them. So in this figure, I have the purple one is a stochastic tree-based reinforcement learning, and then this one is orange one is a Q-learning with a linear function, and then the random forest Q-learning, outcome weighted learning, list-based learning, and our tree-based reinforcement learning. And sometimes if you have overfitting, the tree-based reinforcement learning actually works really badly like this one. In general, the stochastic tree-based reinforcement learning works well. And there are some new challenges when we start to collaborate with our people at medical school. And then many of the time, they want to put some restrictions. So for example, they want some variables. They should not be used to tailor your treatment decisions. Although in your observational data, they are useful for the decision making, for example, health insurance, but you don't want the decision, informed decision rule to depend on insurance. So some variable, you want to rule them out. And that is actually considered in this statistics in medicine paper here. Kelly Spass and me, we have that paper. And another more important restriction actually is on the treatment passes. So for example, not all the observed treatment sequence are still viable or available for future patients. Maybe the drug is withdrawn completely from the market, or maybe the drug is recalled by FDA. And sometimes they want specific type of dynamic treatment regimes. They want stepped up or stepped down type of strategies. They don't want you to jump from one version to another. For example, when you guide the level of care placement for adolescents with the substance use disorders, you don't want them to be inpatient, suddenly go free without any treatment. Okay, so how to restrict these kind of things in your algorithm and in your methodology as well is a big challenge. If we found that if you simply delete the patient records or that, first of all, that will cause a selection bias. Or if you restrict certain path doesn't go through, actually doesn't work either. So it's need you to have, when you have a recursive form for your pseudo outcome definition, you need to consider the estimation within the restricted space. And then also for all the counterfactual, like covariates and even treatment, you need to consider the restricted space as well. So you need to have this kind of constrained optimization at each treatment stage. Okay. So I think, there is nothing fancier, but just have a more clearer, different type of definition there. And then we also, using the simulation, we noticed that so this one is with the restriction, and this one is naive approach with data censoring, without considering the restriction in your method or in your algorithm. So for optimal percentage in stage 1, actually they are doing well. However, in stage 2, when the restriction happened, that works really bad. And if you look at the percentage of recommendation with the viable arm, if you run with the algorithm with restrictions, of course, nothing happened to violate those restrictions. However, if you go with the data censoring and run the reinforcement learning, that can give you some like a very large percent of patients still go to the aim that you don't want them to go. And this is an example, like I mentioned earlier, this is a global appraisal for individual needs, a longitudinal observational data for adolescent substance use. And we want to estimate a viable optimal two-stage dynamic treatment regime to guide the level of care for these kids. And here we have two stages of treatment. After they are diagnosed, enrolled in the study, the 0 to 3 months, and that's the first stage to initiate the treatment. And stage 2 is 4 to 6 months. And of course, you want to optimize the substance use at month 12 after the initial treatment. And here are the possible choices for your treatment will be, for stage 1, you have inpatient treatment, A1 equal to 1, or A1 equal to 2 for outpatient. For stage 2, it could be inpatient, outpatient, or no treatment. And obviously, in this situation, they do not want it to happen that these kids are in the inpatient treatment, and suddenly at stage 2, they have no treatment for them at all. So that in that situation, it's very easily to have reoccurrence for their substance use. Okay. And our outcome is substance frequency scale, which you want to minimize. So we actually put a negative sign in front of it to make it maximize your desirable outcome. And with the restricted tree-based reinforcement learning, we found that the baseline substance frequency scale is very important to determine what initial treatment you should go with. And then later on, the other one is the like environment, how the living risk factor. So this is a living risk indicator index. Living risk index. That is also an important factor to tailor your treatment. And for obviously, because we put the restrictions, or nobody will go with treatment 1 and treatment no treatment at all. However, if even with censored, we get rid of those data who follow that treatment path, but use naive treatment reinforcement learning, you still can get people from treatment 1, and then they will end up with treatment 3, which is not what we want. Okay, and in fact, if you calculate it, the percent of patients who have improved health outcome using this restricted tree-based reinforcement learning, you get the largest improvement among all of them, which is what we want. Okay, any questions? Okay, and another potential option, something that challenge us is, well, you talked about optimal or desirable health outcomes. Yeah. So I'm close. Yeah, very close. So these actually, though, you may have several treatment options have the same efficacy, but they may potentially have different costs, right? So you want that, I don't want to assign only one optimal treatment. I allow several treatments to be within the pool. So depends on the second aspect you are considering, you may want to choose among them. So this is multiple competing clinical priorities we want to consider. And this one, for example, in the cancer research, they actually could potentially have, so this is cancer research for the advanced prostate cancer. So they have 4 chemotherapies. These are treatment choices. And they have 2 treatment stages, initial treatment and salvage treatment. And I want to mention that for this study, they have expert score, which is to evaluate, immediately after treatment, how their cancer tumor respond. But in the long-term run, you also have survival time, which is kind of the quality of life together with length of survival. You want to balance between them, right? So these kind of questions are very interesting to us, and that motivated us to develop this multi-objective tree-based reinforcement learning. And what we did is we introduced one more step to allow the tolerance regime. So that allows us to have more flexibility in treatment choices. And then that can handle various types of covariates without any distributional assumptions. And also the final output is user-friendly and very interpretable. And it also embeds the double robust estimator against model misspecification. And we have a R package for that. So I do not want to go to technical details, but I want to mention this because in many, many real applications, they have multiple outcomes they want to balance together. Okay, and some ongoing other type of research I want, hopefully can inspire some future collaboration. Potentially could be consider different scalarization function to define the purity measure, or incorporate this multi-objective tree-based reinforcement learning in wearable devices, or how to apply this to the EHR data or to clustered smart trial designs. So those are several directions our group are really interested in. And the good thing about this is at the end, you will not only report one tree to your patient or physicians. For example, this is for the cancer research. We actually give them a bunch of the results. So along this direction, if you want to optimize your survival outcomes, you could go with these decision trees. If you want to optimize your quality of life, you could potentially think about this. So you actually offer a bunch of different things to the patients and physicians. It's their choice to decide what is to go in the next step. And toward to the end, what we got from our data, although we said it's evidence-based, informed decision, but it's still to guide them through. It's not like conformative. Okay, to summarize, I hope you can take home some messages that adaptive contrast weighted learning transforms the batch mode reinforcement learning to supervised learning, and that can incorporate the existing classification methods. So it's very flexible, it's very easy to implement. And on the other hand side, the tree-based reinforcement learning can directly deal with the batch mode reinforcement learning, and also estimates the optimal dynamic treatment regime with the purity measure to maximize the counterfactual mean outcome, which is everybody want to achieve. Both of these two methods combines the semi-parametric estimation with machine learning methods, and they can handle multiple treatment stages and multiple treatment options. Okay. And overall, both methods work really well across different scenarios. However, we noticed that tree-based reinforcement learning is slightly have more robustness. But if your decision rule is non-tree type, actually adaptive contrast weighted learning works better. We also want you to take home, like stochastic tree-based reinforcement learning actually has appealing theoretical theory results and also empirical performances. When you have or you observe the data is very noisy, or you observe overfitting, this could be a choice to go with. Or your data is from observational studies, so I highly recommend this. However, you may notice that later on when we develop the multi-objective tree-based reinforcement learning, we did not use stochastic tree-based reinforcement learning. The reason is this is one of the non-parametric type of regression-based methods, needs a large sample size. So if your sample size is limited, actually we do not recommend this. Okay. In the meanwhile, I also want everybody to understand that these methods apply directly to the data when you have restrictions on your mind is not the valid way to go. You should consider other approach like the REST-L or a restricted tree-based reinforcement learning. And at the end, I also introduced how to balance the competing clinical priorities like efficacy versus toxicity, quality of life versus survival, how to get the cost or patient preference into this, integrated into your model, into your methods. That's actually a key research direction in the future. So with that, I'm going to thank all my students who have been working with me, get my tortured during the past 10 years, but they are so productive and all of them are excellent students. And I also really appreciate all the collaborations with my collaborators. Some are internally within University of Michigan, some are actually from other institutes. Peter Thal specifically is from MD Anderson in Texas, and I really appreciate these collaborations. So thank you all very much, and any questions? Say that again, Markov. Oh, number of stages. Yes. So that I didn't go to the details about the tree building process. You're right. So when you start the algorithm, there are actually the stopping rules. So some of the stopping rules are related to the number of treatment of the depths or the number of patients. That we call that as a leaf node size. So size of leaf node, and also the if you remember, we defined the purity measure, how the purity measure increase how much. So those are hyperparameters you need to specify for that. Yeah, and also the whole algorithm, like all the methods I present today, have fixed, like number of treatment stages. We do not allow them to be random, but we do have other research is working with random decisions as well, but these are not. Yeah, very good question.
Yeah, very interesting talk. So, if I understand correctly, on the very last thing you talked about, you were giving different trees based on different loss
Mm, different loss functions. Yes, of course. With restrictions, of course, your loss function will change. But actually, like I mentioned, is the whole process is not only for the tree search. It's also you need to have the good estimate for the counterfactual mean. So when you estimate the counterfactual mean, that part also need to consider the restrictions. Yeah, when you estimate the counterfactual mean, you have an empirical version, and that is a formula you plug in for the purity measure. So basically, how to construct your purity measure need the restrictions, and how you do the search need a different objective function. Yeah, you need both. Mm. Sure. Yeah. So Mm, so yeah, I mean, it's a little more complicated just because this is you want to keep the causal interpretation. So in the causal interpretation, you want that to be have the like null assumption still valid, and you want to get rid of the selection bias. So also we found that even we restricted from the data point perspective, get rid of those who violated the restrictions, doesn't mean like the algorithm itself will come up with the decision rule is still following the restrictions. Yeah. Mm. Mm. Yeah. Yeah, that's actually an excellent question. Again, I put the last part there at the end. Just want to motivate more research in the future. But actually, this part deserve another an hour to discuss. Like you mentioned, I didn't go through all the details. Again, this actually is already published in 2020 last year. So in biometrics, you can read some of the technical details to understand it. One summary from that is we actually use scalarization function to scalarize it. But some other papers we did actually is using the penalization. So you kind of like when you maximize something, you penalize on the second outcomes. And another different approach we have been trying right now actually is using the parental that kind of like to have the look at the pattern of the two-dimensional or even three-dimensional health outcomes altogether. So there are actually three different ways to handle this, but that is a very good question. That's a key actually. Yeah. Mm. Sure. Yeah. Mm. That's actually also excellent question. So far, what we did is do the simple imputation because most of the EHR data, when they handle to us, they already have their programs imputed the value. But I agree with you. I think that is potentially could cause a lot of bias. Yeah, and also especially nowadays, one of the interesting projects I've been involved with is with structured data versus unstructured data, and those unstructured data got missing too much. But how they, the hospital actually have a whole group. What their job is to impute the data by, like they check the whether the imputation model is well. Now they validated all the imputation, so they did that. We just track them. But I agree, how to involve the missingness versus this causal model altogether, methodology wise. That's a very good direction to work with. Yeah.
Gain data already came like with this imputation.
Yeah, gain, yes, yeah.